This was 2003 to 2006. The imaging technology was still new to ophthalmology, and there were so many unanswered questions. We were able to obtain beautiful pictures of the optic nerve and surrounding tissue. However, it was very rudimentary in its analysis techniques, and numerous labs, including my lab that I worked for, ventured into figuring out techniques how to utilize some of these raw thickness data into clinically useful information that could be useful for clinicians. So raw data, let's say for example, if I told you a height of an individual is 5 feet 4 inches, and the normal ranges of height is anywhere between, let's say, 4 feet 10 to 6 feet 5, which is the 95%. I don't know the number, but somewhere there. The value of 5 feet 4 or 5 feet 3 doesn't give you much in that context. So the normal ranges of these biological tissue was so large that identifying if a person has disease or is developing disease or worsening in the disease was very difficult. And so we developed techniques how to analyze the nerve fiber layer data and the optic nerve head data, and to some extent combine it with other devices to be able to generate more robust algorithms that can identify disease early. The good part of this kind of research is that it has developed algorithms for device companies that can utilize these devices directly or these algorithms directly into the device to improve their ability or diagnostic ability. And of course, scientifically, it helped us understand the disease process better. In essence, I have always worked in physiology of retina and glaucoma, and these diseases are considered to be a range or a group of diseases that are not curable, and in fact the vision is best maintained rather than improved. So for years we went behind early diagnosis and perhaps early management of these diseases to improve the outcome of the patient. However, more recently, certain collaborators of mine, UC Riverside and Western University of Health Sciences, have joined hands in trying to see if we can improve the vision in patients with glaucoma and macular degeneration. The idea or the concept is that most common type of macular degeneration, which is the dry macular degeneration, does not have a good treatment methodology. The best scenario we have is to provide vitamins for the patient and maybe hope that they don't become worse in the disease. And what we found was that is almost like a post hoc as to what can we do to keep holding on to what we have. But were there techniques that we can apply to make their vision better? And along came certain visual function questions that stemmed into these broader area that we are working. We wanted to visually train. We know that video gamers and sharpshooters and sportsmen, athletes have incredible vision and reaction time, and much beyond what most humans have. And if that can be trained, so can the visual function of any average human being. And so we are utilizing at-home techniques of improving the contrast sensitivity of patients with disease and trying to see if that overall helps in improving their vision. So for example, if you have a region of damage and you're not seeing so well, the neighboring tissue is okay, healthier compared to this tissue, then one could actually say that let me train the patient's eye overall, and if the neighboring tissue starts seeing better, this damaged area becomes smaller or perceived smaller. The damage is still existent, but at least it's perceived smaller to the individual. And so that brought some of these visual function questions of contrast sensitivity and things like that.